And now I have great pleasure in inviting Gilbert Massard, who qualified in 1984 in the University of Strasbourg and has ended up as professor and head of the Department of Cardiothoracic Surgery in the university, a director of lung transplantation. He tells me he's an honorary professor in Omsk University, which is fantastic. But he did a fellowship in McGill University as well during his training. And he's going to talk to us about surgical aspects of Aspergilloma and invasive aspergillosis. And he's just getting wired for sound now. And I think there's a pointer on the podium. Is there a pointer there? Oh, yes, got it. Merci.
Dr. Scott. Dear colleagues, ladies and gentlemen, first of all, I wish to thank heartfully Professor Denning, who has invited me to come to this nice meeting. And I have to apologize, of course, because I'm the only one who has the disadvantage of being surgeon in the room. So it may indeed seem strange to non-medical people that we propose to do an operation to cure an infection, because in most people's mind, infection means antibiotics. Yet there are several other examples. For instance, in the past, tuberculosis has been a surgical disease before the more potent anti-tuberculosis drugs have been set up. In the eastern and southern countries, echinococcosis is a quite frequent disease in the liver or in the lungs, which may require some surgical intervention also. If we get back to the role of surgery in Aspergillus-related lung disease, we have to mention first that aspergillosis of the lung is not a unique disease, but a complete spectrum. I don't go back into the details because this has been very eloquently demonstrated by Professor Denning earlier today, but I would just like to point out those which are interesting us today. This is, first of all, the so-called classic Aspergilloma. I will explain a little bit later again what this means, and the so-called invasive aspergillosis. It is quite clear that for allergic aspergillosis, there is no place for surgery. The so-called semi-invasive aspergillosis is something which is somewhere between the invasive and the aspergilloma, and may present at the later stage the same way as a usual aspergilloma. So let us go to work and start first with the so-called invasive aspergillosis. This is a very particular situation because patients are usually in a very debilitated state. These are archetypally patients who are cured with severe chemotherapy for acute hematologic diseases such as leukemia, but it may also happen in other patients with immunosuppression, in particular solid organ transplantation. Most often this disease presents as a diffuse infiltrate of the lungs, and then of course surgery is helpless, but there are some elective indications when the disease is localized where surgery may be helpful and even life-saving. Before we go into further details, we have to understand what happens in the invasive aspergillosis. When the immune system has broken down, for instance, owing to heavy chemotherapy, the Aspergillus infection is setting on. Aspergillus is growing into lung tissues and finally begins to die when the immune system recovers, when white blood cells are growing up again and are trying to, how would I say, defeat the invading Aspergillus. In this case, we have risk of fatal lung bleeding, patient coughing up a large amount of blood, when these lesions are lying close to major blood vessels. The second possible scenario is that we have a regression of these lesions with antifungal drugs, and there remain some small areas with dead tissue which are yet colonized with fungal material, and in this case we go into a risk of reinfection when the immune system breaks down again, as for instance when the doctor prescribes a reinduction chemotherapy, or when there is a plan to do bone marrow graft. And of course, if we are planning for bone marrow graft, we have to void out all possible white blood cells. So this is in the upper left the radiologic typical appearance of an invasive aspergillosis at the early stage, where you have a rather dense area in the lung which is surrounded by a more loose contrast. This is usually referred to as the halo sign. If you look at an operative specimen, you see that this is merely related to an area of lung infarction. Then we have the white blood cells who are recovering and who are, how would I say, trying to clean out this lesion, so there is some air appearing within, and you have this kind of a little ball in the center, which is merely necrotized dying lung tissue, which is still colonized with fungal material. On the operative specimen, you have here, for instance, such a lesion, which is a cavity within the lung, and inside is some kind of gray or brown material. This is a microscopic view. The Aspergillus is recognizable with a kind of blue staining as such blue filaments, and the more pink cells are peripheral lung cells. This CT scan demonstrates how dangerous such lesions can be, because you see here, for instance, these points show the branches of the pulmonary artery, and if the necrosis of this tissue goes further, such vessels may disrupt and cause death through lung bleeding. Here you have an extreme situation. This white area here is the main lung artery, and this here, for instance, are the bronchi, and all the dark gray area here is the fungal disease which has grown into the pulmonary artery. Then we have the positive situation when the patient responds to antifungal treatment, and we have some remaining peripheral areas which yet contain some active fungal tissue and may cause reinfection. So what can we do for the prevention of lung bleeding? This would be the first reason to operate such patients. It consists of detecting at an early stage the halo sign, and then to monitor closely with repeated computer tomographic scan. And at once the lesion gets close to a large blood vessel, when the fat rim, which usually exists around the vessels, disappears, it is time to go and operate. However, you see that this is not a very frequent situation. The first report, which is about 10 years old, described only 8 patients. Hopefully there were no deaths during surgery, and only 2 of them progressed with their fungal disease. There are several other reports which have been published meanwhile, concerning as well adults as children, and we get the general impression that the postoperative death rate is less than 10%, which is maybe to your eyes a little bit high, but considerably lower than the spontaneous course of such patients. So the second idea to operate such patients is to eradicate infected tissue to reduce risk of infection, in particular in patients who are planned to undergo bone marrow graft. So this surgery is performed when there has been a complete recovery of the bone marrow following medical treatment, although it is quite difficult to say how long such patients should be treated, although we have also the planning of the bone marrow graft behind, so there is a time constraint anyway. And this surgery has only a sense if we can perform a limited removal of all infected areas, which is also a kind of indication or contraindication to surgery. If we have to remove too large an amount of lung to be able to remove any infected tissues, and that the patient cannot survive any longer, it is useless to perform such surgery. So what is the risk of surgery in this context? Prevention of reinfection, removing of damaged tissue. We have an idea, if we take together some published work, that the operative death rate is about 10% again. And if we look how many patients actually do relapse with their fungal disease, it is also about 10%, which is a quite satisfactory achievement. So the interesting idea we get from all this is that there is a relatively reasonable complication rate. This is owing to the fact that most of them are young patients, children or young adults, that there is no serious underlying disease, no associated cardiac disease, no chronic lung disease, so that the lungs are normal outside of the infected areas, that the pleura, which is the cavity around the lungs, is free from any adhesions, and as we say, that respiratory function is normal. And the second point is, especially when we are removing these remaining small infected areas, we can do very limited peripheral lung resections, which conserve, of course, as many lung tissue as possible. Let us now move to another subject, which is the so-called traditional aspergilloma. You remember certainly from Professor Denning's talk these large holes in the lung in which you have a fungus ball which is progressively growing. There are several reasons for lung to have such holes, but historically the most famous was tuberculosis, which was eroding the lung, and when tuberculosis healed, this hole stayed and was secondary colonized by Aspergillus, which was purely inhaled by the patient. Meanwhile, tuberculosis has been got under control, and the more frequent events nowadays are either emphysema or other granulomatous diseases such as sarcoidosis or lung abscesses, lung infarctions, and so on. Aspergilloma is, again, not a single disease. As we said, that there are different basic diseases, so there are also different behaviors in patients. And the most efficient classification, I apologize, is almost as old as I am myself. It has been published in 1960, and it is quite simple because it distinguishes only two categories, which is the simple aspergilloma and the complex aspergilloma. This is quite easy to understand. The simple aspergilloma is a little hole in the lung with a thin wall around it, with otherwise, I'm sorry, this is not the kidneys, healthy lungs around, and such patients usually have no symptoms. That means they have no cough, they are not coughing up blood, they have no sputum, and they have a normal lung function. On the opposite, we have the complex aspergilloma. There are larger holes with a rather big wall around it. Lung tissue around is scared, and if we look closer at the patient, we see that he has severe symptoms and complaints, disabled lung function, and above all, poor general health status, and especially severe denutrition. So this is from a paper we have published several years ago already on an Alsatian population, if I can say so, where we have the complex Aspergilloma here, the simple here. So you see that the complex is older, that they have less weight, they have less lung capacity. If we look now at the treatment of this Aspergilloma, what can the surgeon propose? Well, the ideal treatment would be to remove both the fungus ball and the disabled part of the lung where this fungus ball has developed. This means that we can remove either a small part of the lung, which we would call a segmentectomy, or we could remove a lobe of a lung. You know that the lung is divided in 5 lobes. There are 3 lobes on the right side and 2 lobes on the left side. Removal of a lobe is called lobectomy. Or in some cases, when the disease is more extensive, it would require the removal of a whole lung, which we refer to as pneumonectomy. We should right now warn that the more lung we remove, the more dangerous is the operation for the patient, and especially pneumonectomy is a very dangerous operation also in this situation. So many physicians who are not surgeons know that such operations may be very difficult, especially in complex Aspergilloma, which happens more often in patients with previous tuberculosis, that there is a substantial risk of post-operative complications and even post-operative death. So it is always a kind of dilemma for the surgeon and the referring physician to decide when to operate. Should we operate on a routine basis to prevent sometime occurring fatal bleeding or significant bleeding, or should we say it is a potentially dangerous surgery and we should only operate patients with symptoms, knowing that these are the most difficult to handle? So I tried to get you some ideas to get out of the wood. So if we have a simple Aspergilloma, which is a small limited lesion, usually without systems, we can say that we don't know the exact course of the natural history of the disease. That means what will happen if we don't do anything. Will the Aspergillus grow? Is there a risk that a patient without any symptoms will start coughing up blood some months or years later? And is there any risk for invasive aspergillosis, especially if the patient gets into an immunosuppressed status? That are some question marks, but what we can say, and quite affirmatively, that is that the operative risk definitely is low in this category. Here is an example of a simple Aspergilloma. As you see here, the fungus ball, and then the cavity round, which is a fine-lined wall, which looks quite nice. The lung around looks rather normal. And this is a very interesting case because we were able to find previous x-rays, and you see that all has started with a nice little hole in the lung with a very fine lining around and just some thickening in the lower part. 2 or 3 years later, you see that this lower part has grown, and this was already the beginning of a fungus ball. And then again, 2 or 3 years later, we get at this stage. This patient was still without any symptoms, but we had the proof that the fungus ball was growing, and in that way it was quite easy to decide to do an operation, which was a very simple, uncomplicated lobectomy with a very smooth post-operative outcome. This is still a simple Aspergilloma, but you see that it may already become a little bit more tricky because here there's a little bit more thickening. You have this whitish thing here in the lung, which is also kind of fibrosing process around. Although it seems well limited to the lobe, you see here this nice little line, which is the separation between the lobes, which doctors call the interlobar fissure. The complex aspergilloma now, this is of course a much more detrimental situation. The lesion is usually larger. The disease, the lung which is surrounding is diseased. As I said, quite often these are patients with previous tuberculosis. They have poor respiratory function, they are malnourished, and they have very serious and annoying symptoms. And of course, the most dangerous for the patient, the most dreaded by his doctors, is coughing up of blood, which may go up to considerable amounts. We know pretty well that in such patients we have an increased operative risk, but also an increased spontaneous risk. And here are some examples. You see that this is a quite different shape. We have any longer nice rounded, well-limited hole. It is a larger cavity. The fungus material is much more abundant in volume. This here is an even more important lesion, you see, which is destroying almost the entire upper part of the right lung, extending down to this level. And then here we have a historic example of almost a whole lung which is destroyed by the fungus material. So which surgery can we afford in such patients? Ideally, we would like to do a resection limited to a lobectomy, but this can be technically difficult because, of course, there are adhesions of the lung to the chest wall, which will bleed when we are trying to cut them. There will be a fibrosis around the vessels and the bronchi which are going into the lung, which will be difficult to dissect, and there may be an involvement of the adjacent lung tissue and lobe. So we expect in such patients post-operative complications, especially bleeding. We expect also that the remaining lung will be a little bit stiff and will have some troubles to fill up the chest cavity, and there is an increased risk also of post-operative pneumonia. And I wish to repeat again that removal of an entire lung in this situation is a high-risk surgery. We have some figures to prove that. This here represents patients who have been operated for a destruction of a whole lung by some kind of chronic infections. And this bar here represents patients who had Aspergillus infection and those who had no Aspergillus. And the pink area are those who had severe complications, which means infection of the pleural space after removal of the lung. And you see that in those patients with Aspergillus, it occurred in virtually all of the patients. Well, let's go over this. What alternatives can we propose to such patients if we know that the surgery is dangerous? The first thing we can do in an acute setting when the patient is coughing up a large amount of blood is to do an embolization of the so-called bronchial arteries. These are arteries arising from the aorta, which are going along the bronchi into the lung, and most often these vessels are responsible for the bleeding. And these vessels can be occluded by a transcutaneous catheterization. A second concept is to ask an invasive radiologist to inject antifungals directly into the lung cavity. This procedure can be performed under local anesthesia, under computer tomographic guidance, but there of course is a risk that the fluid we inject into the cavity may flood into the lung and the patient gets into trouble. And even if we are successful if we are able to kill the fungal material, the cavitation persists, and it is very likely that sooner or later the aspergillosis relapses. So the final solution we have is just to simply put a drain into the cavity to clean it up, to remove the fungus material, and to do anything more. This can be helpful, but is of course an invalidating procedure, because either the patient remains with a chest tube or even an opening of the skin directly into this internal cavity. We have another alternative to resection, which is a little bit more aggressive, but which procures a more definite status to the patient with a potential cure. This consists to open up under general anesthesia the chest, to remove the fungal ball, and then to try to collapse the area around the cavitation in the lung. To do this, the surgeon has to remove several ribs that may be as few as 3, that may be as much as 5 or 6. And when you remove the ribs, the peripheral muscles will just fall onto the lung and will occlude the cavitation. This allows for a complete one-stage curative treatment, but of course is also subjected to substantial surgery risk, because as we said, those patients who have an extensive disease which is not amenable to a simple removal of a lung lobe are usually in a poor health status, because they are malnourished and they have a very poor lung function. There is perhaps, among others, one ideal indication, which is aspergillosis complicating treating for lung cancer. I mean by this, patients who have been subjected to removal of a lung lobe for cancer, who got radiation therapy afterwards, and who develop at some stage an acute infection with Aspergillus and end up with a picture like this. There, of course, there's no way to say we remove the remaining lung, because it will not be helpful for the patient's breathing, and we will spoil all this material into the chest cavity, end up with a much larger infection. So the good idea in such a patient is just to remove the upper few ribs and maybe to put actively some muscle inside, just to occlude the whole system. So this table shows now the comparative operative risk between simple aspergilloma and complex aspergilloma. And you see in this column that in most series, the daily series goes back to the 60s and 70s, so circumstances in hospitals were different. But in the more contemporary publications, there is virtually no death after treatment of a simple aspergilloma. If you look in this column, of course, complex aspergilloma has a risk which is quite high and which may be summarized at somewhere of 15 to 20%. It depends how long we wait. The longer we wait, the higher is the risk, of course. And then it is also interesting to compare two time periods. This here represents the time period from the middle of the 70s to the beginning of the 90s, and this here is the late period of the 90s. We see that the patients are slightly younger, and especially there is much less tuberculosis, and there are half as much complex aspergillomas. So the fact that tuberculosis is going back lines quite well together with the regression of complex aspergilloma. So if we look at the complication rate, again, between the two time periods, we see that an immediate thoracoplasty, that means removal of the ribs to fit the chest wall to the lung, was necessary in half as less the patients in the later period. Bleeding occurred much lesser in the more recent time periods. The same what concerns infections and air leaks in the pleural space, and the hospital stay, of course, has been considerably reduced also. And last chapter I would like to go through quite quickly, because it is a very exceptional but very serious problem, is the so-called pleural aspergillosis. That means that the space between the ribs and the lung, which we call the pleural space, gets infected with this aspergillus, and this usually is no longer a fungus ball but a kind of just a fluid which is positive on microbiology. There are two settings. We have such complications very early after a lung operation. Then, of course, it is quite clear that the aspergillus has been put into the pleura at the time of operation. That means that most often this happens after operation for a known or unknown aspergilloma, and the surgeon unfortunately has opened the cavity and the aspergillus can seed into the pleural space. We have another setting that is onset many months or years after lung operation, and here the reason is a little bit different. That means that there is somewhere a communication between the bronchi and the pleural space, and during inhalation of fungal material, the patient gets infected. How can we cure such patients as a surgeon? Well, to heal any kind of infection in the pleura is that we need to obliterate the residual space. That means that the lung has to get back to the ribs and there should be no space left around. To do this, the usual operation is called decortication. When you have an infection in the pleura, the cover of the lung gets thicker and impedes the lung to get back to the ribs. So what the surgeon does in such situations is just to peel the surface of the lung to get it smooth and expandable again. Another option is, when you cannot free the lung in this way, is to try to free a peripheral muscle and to put it inside the chest. This is, however, not always possible, because at first most of these patients have already got an operation, so the muscles have been cut and are of poor quality. The second point is that often the space is quite large and the muscle may not be sufficient, especially in such patients who are undernourished. Another option which has been popular is what we call the open chest drainage. That is just to make a hole into the chest wall by removing one or two ribs and by sewing the skin inside to have this opening staying open. And this, of course, allows doctors and nurses to do garments any other day and to clean progressively the space, but leaves the patient with a very uncomfortable situation. So the final possibility is, again, the good old-fashioned thoracoplasty, which, by the way, is an operation which has been initially designed to treat lung tuberculosis. And this consists, in fact, in simple words, to tailor the chest cavity to fit the lung. If the volume of the lung is reduced, we have just to remove as much ribs as required to get the chest wall close to the lung. So, which results can we observe? Well, it is difficult surgery in difficult patients, so it is not surprising that there can be post-operative deaths. Complication rate is high, with 2 patients of 3 experiencing some severe bleeding, 1/4 requiring a second operation, and 2/3 staying more than 30 days in the hospital. But the good news is that all 13 surviving the operation at medium term had their antibodies turning lower or even negative. Oops, it was a little bit, well, I want just to show something to relax and then to go to another aspect which is important in these patients. That means that it is not enough that the surgeon goes in and operates. There needs to be a more multidisciplinary management, and this concerns as well the preoperative as the postoperative period. The most important aspect, to my sense, if we want the patient to heal after the operation, is that he has enough calories intake every day. And so if the patient is not able to eat as much by himself, we have to feed him. And to feed the patient, there are only two ways. Either we have to bring the feeding into the gut. This can be achieved either by putting a small tube through the nose into the stomach, or to put a tube directly through the skin into the stomach. The other way is to put intravenous fluids with high calorie input to remaster the patient. The second important point, of course, is optimization of anti-infectious treatments. If we are thinking of surgery, and even in patients who are not going to surgery but to have increased production of sputum, it is quite interesting to do intensive chest physiotherapy. In those patients who have poor lung function, poor nutritional status, exercise training is a very interesting concept. We know that these patients are definitely not able to do a large amount of efforts, but if we have them train every day at a low level, we will progressively increase their potential. And then we should never forget that these patients are often also in a kind of psychological distress situation. Psychological support is important, and unfortunately, this is a kind of disease, especially the Aspergilloma, the more chronic things, which are more frequent in the low-income part of our population, and we should think of the social problems, what happens to those patients who lose their job because they are sick. There should be some input from the side of social workers also. And I wish to go to the conclusions and to say that surgery is possible in selected cases of patients with thoracic aspergillosis. We have seen that there is a broad spectrum of diseases and of remaining indication, and this despite that we have increasingly potent antifungal drugs. It is a difficult surgery. It requires to be performed by a well-trained and experienced, I underline, thoracic surgeon who is used to such operations. It is not kind of surgery to do 2 times a year. There is a risk for complications in the patients. We should be honest and tell it to the patient, to their family, to their referring doctor. And we should not just like that decide to go on and operate. Such a surgery needs to be discussed with other colleagues. I mean by that specialists for infectious diseases, specialists in pulmonary medicine, intensivists, to carefully weigh the risk and the benefit and to decide really on an individual basis what to do with the patient. I thank you for your attention.
Merci bien, Gilbert. Are there any questions for Professor Massard? I'm fascinated by the way it's all coming back, because I remember thoracoplasties and stuff when I was a kid, and I remember patients with holes in their chest left over from, and it was always a curiosity. You know, they were quite well, and they were in outpatients generally. It was a curiosity to us. And it's interesting to me that you're proposing these volume reduction strategies now for when you can't close up that pleural space or fillet. Can I ask a question? How do you decide that you're going to take this step and do an operation? You're presented with a patient.
Well, to decide, we usually do not decide alone. I mean, I see the patient in my consultation. I have a look at him. I have a first idea, but we go back to the referring pulmonary doctor. We show the patient to an intensivist. Right. We ask a specialist. We have the chance to have Raoul Herbrecht in Strasbourg, who is well renowned in the field of fungal diseases. And then we try to do the best decision with the input of the best colleagues we can involve. But basically, in as far as we talk about invasive aspergillosis, that means the patient coming from the hematology ward, usually the selection has been made by the hematologists. They are in a situation where they cannot go further because they are at the end of what is possible with the antifungal drugs. So all we have to consider is if anatomically we can do the operation and if the lung function allows us to do so. Right. If we are in the situation of Aspergilloma, I advocate to be more aggressive in the case of simple Aspergilloma, where the patient has no symptoms, normal lung function, and will most probably go through the operation with no or minor complications. Right. If we are in the situation of complex Aspergilloma, that is perhaps the most difficult decision. And well, sometimes the situation is so that there are such severe symptoms that we have to do something quickly, sometimes even immediately. And it ends up that the most annoying patient at the end for us, if I can say so, is the complex Aspergilloma who has low symptoms. Okay. Because there we can shorten life expectancy by being too nervous as a surgeon.
Yes. Are there any questions now? Anyway, thank you.
For an invasive aspergillosis, how much time has to pass before to start another chemotherapy from the surgery for you?
Well, I mean, to my opinion, you can start the chemotherapy as soon as the patient has recovered from the surgery. That means if he has no complications, the chest tubes are usually taken out between 2 or 4 days after the operation. He may leave surgery 6 or 7 days after the operation. So 2 or 3 weeks later, if the hematologic situation requires that you have quick reaction, you can take the patient back to chemotherapy. If the patient gets complications, of course, it can go up to a dramatic situation where the hematologic disease progresses or relapses before you can act because the patient is still recovering from the operation.
Okay. Well, thank you very much indeed.